Good evening. Sorry, this is Dr. McDaniel. It's Sunday, April 28th, and as I started yesterday, the menopause, I'll be continuing that today, a word on menopause. So, yesterday I spoke about how the average age for menopause is between 52 to 54, but it can range as anywhere between 42 up through 57, 58 is still within normal limits. One is considered young for menopause or having an early menopause, what we'd call a premature ovarian failure, if they are under 42 years old. So 52 to 54 is the average. Most women will have symptoms that they're going through menopause. We call those perimenopausal symptoms. Anywhere from a couple of months up to 2 years is the average before they're actually menopausal. Less than 5% of women will have absolutely no symptoms whatsoever, just they don't get any more menstrual cycles. The definition of menopause is a woman who has not had a menstrual cycle for at least 12 consecutive months and has either the traditional or classic signs and symptoms of menopause and or has had her hormone levels checked to confirm that they're consistent with menopause in the face of not having cycles for that 1 year time frame. The most common symptoms of menopause that someone's going through menopause and that they've already gone through menopause are several. Most common are hot flushes and night sweats or sweats throughout the day. As I mentioned, most women will start off as having just hot cheeks, hot face, comes for a few seconds, goes away. Could be a couple times a day, a few times a week, could be several months apart, and then it will flourish or mature often into heat that starts in the chest, works its way up through the crown of the head, and then drenching in sweats, beads of sweat and then drenching. Those are hot flushes and sweats. Insomnia, some mental, not so much confusion, but forgetfulness and just kind of cloudy fogginess is how a lot of people describe it. Any of the classic premenstrual symptoms are also symptoms consistent with perimenopause or menopause. That would be breast tenderness, bloating, appetite change, acne, headaches, usually frontal or back occipital headaches, occasionally blurred vision, but that's not very common, muscle aches, flu-like symptoms, joint pain, fatigue, insomnia, moody, emotional, angry, irritable, anxious, depressed, and vaginal dryness or irritation, discomfort, change or decrease or shift in libido or sex drive, and urinary problems for some women. Increase in urinary infections due to changes in the urethra from the loss of estrogen, and or just urinary leakage issues due to changes in the pelvic muscle tissues becoming thinner and weaker. Classically, most women will have 1 to 2 years of symptoms and then they'll be menopausal. Most women will follow their mothers or older sisters in terms of signs, symptoms, and changes before and how they go through menopause and the age at which they go through menopause, unless there are extenuating or external environmental circumstances. And those circumstances would be ones that affect the ovaries so that they lose their function or capability earlier than anticipated or expected or would be normal for that individual. The hormones that we check to confirm that someone is either perimenopausal or menopausal are 3. We call them all ovarian hormones, but two are actually from the brain. They affect the ovaries, and the third one's from the ovaries. The two from the brain are FSH, or follicle stimulating hormone, and LH, which is luteinizing hormone. The third one is estradiol, or estrogen, which is one of the major hormones from the ovaries. The first two function throughout reproductive life to mature, to develop an egg from the ovaries, and to allow it to ovulate or be released in order for pregnancy to occur. So the follicle stimulating hormone is the hormone that helps increase or mature the development of the eggs, because we call eggs follicles. And the luteinizing hormone aids in that production on the second half of the production to increase the maturity. The estrogen is produced to support the egg development and to aid with the maturity. When someone is having menstrual cycles monthly, those two hormones, the first two, LH and FSH, will rise in order to produce that egg and to allow it to develop to the point where ovulation can occur. And the third one, the estrogen, supports that development. Once someone has gone through menopause, the brain keeps producing that hormone more and more and more and more and more to try and produce an egg, but obviously because the ovaries are no longer functioning normally, there aren't any eggs to be produced, so it just gets higher, higher, higher. Whereas if someone were menstruating, it would produce those hormones so they get high, high, high until the egg is produced. Ovulation occurs, it's done its job, then those hormones drop again, so that with the menstrual cycle, the first two hormones, LH, FSH, are very low. They're usually less than 5. And the estrogen level is also low because there aren't any eggs to support. When someone goes through menopause, the brain keeps trying to produce the hormones to develop an egg, but since there isn't an egg to develop, it just gets higher, 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 persistently stays elevated. However, because there aren't any eggs being produced, the estrogen level also stays high, whereas if someone were just pre-ovulation, so just about to ovulate, all three of those hormones would be elevated, the LH, the FSH, and the estrogen or estradiol, because it's supporting all of the egg development. With the menopause, those first two are high because the brain keeps trying to produce eggs, doesn't realize that there aren't any eggs to be produced, but then the estrogen level is low because there aren't any eggs being produced, so there's nothing to support. So those are two definitive ways when you're just looking at the blood test to ascertain that someone's menopausal and not just about to produce an egg or not pre-ovulatory status. It's the loss in the estrogen or the fluctuations in the shift in estrogen first that is the source of all of the perimenopausal signs and symptoms. The most, I would say, destructive is the fact that the estrogen levels are maintained at a low concentration. So a lot of the pelvic and genital tissues are supported by estrogen. So the vaginal tissues are moist, plump, and supple because estrogen is producing that moisture, that plumpness, and that suppleness. After menopause, when someone doesn't have those estrogen levels, the lack of estrogen or that estrogen deficiency is what causes the vaginal tissues to get dry, thin, tight, firm, non-pliable, non-elastic. We call that vaginal atrophy because atrophy is just the shrinkage and the drying and the tightness of tissue. And because the vaginal tissues are responsive to estrogen, when someone's starting to go through menopause, we can see that shift in the estrogen effects where the vaginal tissues get thinner. They lose their kind of lumpiness, rumpleness, and plumpness. We call that rugae. And then after menopause, the tissues get very dry, very thin, somewhat fragile. And that can lead to pain, discomfort with intercourse because the tissues are not elastic, they're not pliable. So the stretching with intercourse is painful, the friction is painful. Sometimes women will bleed or easily tear. The loss of estrogen also leads to urinary problems because the bladder is a pelvic muscle, pelvic organ, and it also responds to estrogen. So the lack in estrogen decreases or thins out the lining inside the urethra, the urethra is the tube that goes from the outside environment to the bladder. Because it's thin, it loses part of its defense mechanism against bacteria, and with normal activities, bacteria gets into the urethra. It's easier to get a bladder infection. The pelvic muscles act like a sling or trampoline for the pelvic organs, and the pelvic organs are the bladder, the uterus, and the rectum. Because those three organs sit on the pelvic muscles, they're supported by the pelvic muscles. And when estrogen depletion occurs or estrogen deficiency occurs, that muscle, which responds to the estrogen, just like the vaginal tissue, just like urethral tissue, it gets thin, dry, weaker, and then it's much easier for women to have urinary problems because, as I mentioned in the previous presentation, the bladder sits on the pelvic muscle, and when the pelvic muscle gets weak and thin and compromised, the bladder drops and is susceptible, the sphincter is susceptible to urinary loss. So with increased abdominal pelvic pressure, coughing, sneezing, laughing, exercise, urinary loss, what we call genuine stress incontinence, can occur. It was years ago thought that the heart and the brain also respond to estrogen levels, which are elevated during reproductive life. So I mentioned earlier that I would speak about the Women's Health Initiative, which was a huge project that occurred for about 8 years or so and was concluded around 2003-2004. That initiative took thousands of women and put them in research categories with different aspects of life and environmental influences. Prior to that study, it was thought that the reason why women have fewer issues with cardiac disease than men was because women have a protective effect due to estrogen. And it was also thought that the reason why women's risk of cardiovascular disease or heart attacks increases after menopause towards the same levels as men is because we lose that estrogen effect. That makes a lot of sense. We had fewer rates of cardiac disease or cardiovascular disease before menopause, and then we reached the same elevated levels as men after menopause. So I remember in the 90s, we were giving hormone replacement to everyone. It was like, I used to tell patients in the 90s, I used to say, hormone replacement is the fountain of youth. And it can impede, retard, or potentially reverse all of the effects of aging due to menopause or estrogen deficiency. And I had a colleague who used to say that menopause is a disease. It's a disease because we have a lot of negative effects that occur in the bodies once women have gone through menopause. And as all diseases, we should treat them. We should treat them with hormone replacement. And I remember for a good chunk of time, several years, a lot of the cardiologists were prescribing hormone replacement or recommending that women see their gynecologist for hormone replacement to decrease the potential and elevated risk of cardiovascular disease once they've gone through menopause. Well, the Women's Health Initiative showed that the potential benefits of hormone replacement will only be helpful if you have absolutely no break in those elevated levels of estrogen. So women who had gone through menopause 2, 3, 4, 5 years prior to all of the the increased surge in prescriptions for hormone replacement, they were being placed on hormone replacement and it wasn't helping at all. In fact, it was hurting. The study showed that there was a slight increased rate of cardiovascular disease or heart attacks after women were placed on hormone replacement. I'm new to this whole Facebook Live thing, so I see Bunny James. Thank you so much for watching. This is fun. You said you're getting a lot of information, and thank you. God's blessings to you. That's very sweet of you. Thank you so much. Warms my heart. So the Women's Health Initiative kind of knocked down the recommendation for hormone replacement for cardiovascular disease. And what it showed was you really, as soon as you started having perimenopausal symptoms, you needed to go immediately on hormone replacement. Another area where the hormone replacement was recommended was because we were seeing that women who'd gone through menopause had the mental fog, the memory loss, and it looked like Parkinson's disease increased after women went through menopause. And a lot of the neurologic scientific information was showing that some of the neurologic bundles that were seen in the brain improved after hormone replacement was started. So women were also being placed on hormone replacement in order to decrease the memory fog and the memory loss that was occurring. The jury was still kind of out on that, but the Women's Health Initiative showed potentially that it did not statistically make a large enough difference to overcome the potential risk of women going on hormone replacement. Because in science and in medicine, of course, the biggest question is, what's the risk versus benefit? So if the benefit doesn't outweigh the risk of going on a medication, it's not worth going on that medication. The catch with the hormone replacement was that it had a lot of potential benefits. So hormones replacement is just as it says. We are medically replacing the hormones that you lose going through menopause. So the major hormones are, the major hormone is estrogen. All of the problems are due to estrogen loss, estrogen deficiency. The catch is, if you still have a uterus, you need to balance the estrogen with progesterone, because just taking estrogen by itself, A, is not natural, and B, it increases the risk of uterine cancer or endometrial carcinoma without having the balance of progesterone to prevent abnormal buildup of tissue in the uterus. So all of the problems that ensue because of menopause, all the symptoms I mentioned, everything is due to estrogen deficiency. So the thought was, rightly so, let's just give women the estrogen they lose when they go through menopause. They just keep on trucking with the estrogen. We won't have all the estrogen deficiency loss or sequelae or complications. Everyone will be happier. It's a win-win situation. The problem was that the Women's Health Initiative confirmed what we already knew, and I used to tell women before the WHI studies were completed that there is an slight increased risk of breast cancer, because the breasts are hormonal organs, so they respond to estrogen. And unfortunately, a large percentage of cancers are hormonally responsive, which means they grow and feed off of the natural hormones in our body, estrogen and progesterone. That's why when someone has breast cancer, the pathologists look to see if there are hormone receptors for those cancers to see how we can direct treatment. Unfortunately, if someone's gone through menopause and they don't have those hormones, but then we suddenly give them the hormones, we're potentially stimulating breast cancers that in other circumstances would not have thrived. So the Women's Health Initiative confirmed that there is a 1.1 increased relative risk of breast cancer. And for that reason, all of the recommendations for hormone replacement were shut down on a dime. Okay, so I've been talking a long time, trying to keep track of the time. That's going to be, oh, and I just remembered yesterday I was speaking about the supplements. I couldn't remember what the additional one was with the progesterone cream. I'll go over that again, but the supplement I was thinking of, I thought of course later, is black cohosh. That can be taken as a tea or a pill, and in conjunction with the progesterone cream, it helps a lot for hot flushes and sweats. So I'm going to stop there now. I'm trying to keep track of the time. I think I've been about 20 minutes now, so twice as long as I want it to be. And then tomorrow, we'll take up the torch again, and I'll continue speaking on menopause. Hope this is helping everyone. Hope everyone is gaining information that they wanted from GYN Corner. And this is Dr. McDaniel. It's Sunday evening. Thank you so much. Have a blessed evening and see you tomorrow.